Now, the common medical problems in the elderly that we have, well, there's a lot of them. We can think of any of these that would focus around a primary complaint. Um, with a primary complaint, we would typically see things like in pulmonary disorders or in the respiratory system, decreased chest wall compliance, loss of lung elasticity, increased air trapping due to collapse of smaller airways, and then the reduced strength and endurance in the respiratory muscles. Most elderly patients present with a chief complaint of dyspnea, so that's where obviously we're going to start. But there are so many factors that can trigger respiratory distress that we need to be aware of. These include things like heart failure, chronic bronchitis, PEs, pneumonia, pulmonary edema, heart attacks, asthma, or even things like emphysema or COPD. So again, we have to recognize that these disorders do exist and that the potential complications of each are going to have a bigger impact on our geriatric patient. Another one that we don't typically think about as an acute problem is lung cancer. But we do know that the geriatric population, especially those that have a history of cigarette smoke, are more prone to cancer of the lungs. Pneumonia. The elderly develop pneumonia more frequently. This again is because of the fact that they can't expel any of the pathogens that may have gotten into the lungs, so the normal coughing reflex being weakened. We know that the fever may be absent in the elderly because their body's not able to fight the infection as much as they once were, so it's more difficult to assess for that. It's also more difficult to for their body to be able to fight that infection. Most of the management and prevention strategies when we think about pneumonia are really going to be focusing on remaining active, making sure that we stay away from cigarette smoking, and that we do as much as we possibly can to follow up with our primary care physicians early rather than waiting for something to become more problematic later. We also know that pneumonia is very commonly going to be associated with a complication of another underlying pulmonary disease such as COPD or emphysema or asthma. Chronic obstructive pulmonary disease, again, we're talking about airflow issues that are obstructed. We have reversible and irreversible. A lot of times these elderly patients will come in and they're going to have irreversible problems. Remember that COPD is progressive and debilitating. A pulmonary embolism, we're talking about blood clots. This is most likely the frequent cause. These originally come from the veins in the legs, from the DVTs in the legs and the thighs, that calves that move upwards. Our care is the same as for any patient who's suffering from a pulmonary embolism, recognizing that we're having an impaired pulmonary and cardiovascular circulation, so oxygen therapy, IV therapy, anticoagulants, vasopressors, and then obviously positioning may play a role in our care. Pulmonary edema, we know that pulmonary edema in the elderly can come on very quickly. We call that flash pulmonary edema. It can be from any number of things, from infections to inhaled toxins to overdoses, pulmonary embolisms, even things like atmospheric pressure changes. We want to try to treat whatever the underlying cause is, and then think about those BLS non-invasive interventions we have, such as CPAP, and then other ALS interventions we can do to help provide additional relief for our patients suffering from pulmonary edema. These include things like nitroglycerin. We talked about the use of our CPAP, and then also beta agonists as necessary for bronchoconstriction. Lung cancer, this is more progressive than some of the other ones we've been discussing, but it is a progressive dyspnea that may first be presented with cancerous lesions. Neoplasms referred to as new growth. Hemoptysis, which can be having that bloody sputum. You're going to see chronic cough, weight loss are also very common problems associated with lung cancer assessment findings. There's no way for us to definitively define if someone has lung cancer in the field versus that of tuberculosis. So we want to make sure that we again take body substance isolation precautions, appropriate PPE, and then make sure that we're communicating our plan both to our patient and to the receiving hospital. Cardiovascular disease, there's a lot of cardiovascular disease. A number of the variables unrelated to aging influence cardiovascular function. These are things like diet, smoking, alcohol use, education, socioeconomic status, even personality traits, believe it or not, affect your heart. Of particular importance is a level of physical activity. Even though the maximum exercise capacity and maximum oxygen consumptions decline with age, a well-trained elderly person can match or even exceed that of the aerobic capacity of an unconditioned young person. And so, in essence, what that means is just because you're young doesn't mean you're better than an elderly person. It really depends on a lot of the factors that you partake in with your life. And we'll explore those as we go through this a little more. But let's take a look at some of these common issues that we typically see. With angina pectoris, this is usually triggered by physical activity. The attacks that they may have will vary in frequency, and it depends on their previous history. Sometimes angina is considered normal for patients who have a very weakened heart, especially if they have comorbidities like diabetes or a smoker or heart failure. Most of the dyspnea that we see is going to be is more likely a symptom of angina than pain in the elderly. They're not going to respond to pain by an increased respiratory rate as much as they are going to respond based on distress of the heart. General prevention strategies in the elderly are similar to those in young patients, and we know what the difference between angina and an MI. An angina will come and go depending on treatments, and an MI it remains constant, and we're dealing to myocardial death of the tissue of the heart. Unstable angina is where we've now had medication administered, it's not been effective to our patient, or it's not been relieved with rest, or it's continued for a prolonged period of time. That'd be a definition of unstable angina. A myocardial infarction, these patients, because of their age and because of their underlying issues, are not going to present with classic symptoms. We oftentimes will refer to them as the silent myocardial infarctions, or the atypical presentation for acute coronary syndrome. We know that they're on a lot of medications. It leads to a lot more complications, including things like dysrhythmias, especially if they're suffering from some type of MI. It's likely that they're going to go into cardiac arrest. Dysrhythmias are the leading cause of death in the initial hours following an MI for a geriatric patient. So early detection and emergency management is critical in order to help ensure survivability of our geriatric patients suffering from an MI. Heart failure, again, we know cardiac output cannot meet the body's metabolic demands. The blood flow cannot continue to move forward. We look at this as primarily 4 categories for heart failure in a geriatric patient. These are things we've also talked about, including impairment of flow, so an increase in afterload, typically that has to do with hypertension or peripheral vein disease. Inadequate cardiac filling, that means a decreased preload, typically dealing with something with the right side of the heart. Volume overload, they be taking in too much fluid. This is very common if someone is typically on diuretic and they eat a lot of salty foods like popcorn or chips, hot dogs, they've gone to the fair, that type of thing, and they've enjoyed themselves. Well, now they've got all this fluid retention, which can lead to an increase in afterload. And then myocardial pump failure, so we're talking about left or right-sided heart failure or a bilateral heart failure. The risk factors associated with that are just of that of any other cardiac patient. Signs and symptoms of heart failure include edema, that's pretty noted. Fatigue is most commonly associated with left heart failure. Two-pillow orthopenia, where they have to have 2 pillows behind their body in order to, behind their head in order to be able to sit upright enough to have the adequate real estate for gas exchange in the lungs. A dry, hacking cough that progresses to a productive cough. Paroxysmal nocturnal dyspnea, or PND, they can't sleep laying flat at night. Dependent edema, that's again a sign of right-sided heart failure, whether you're dealing with pedal edema, sacral edema, things of that nature. We also get a whole bunch of other components that are associated with that too. Hepatomegaly is another example that you might see, anorexia, ascites, and then dyspnea depending on exertion. Now, heart failure, there's a couple different ways that they can manage it. The first is they try to do non-pharmacological interventions first to see if that makes a difference in the patient's lifestyle, things like modifications to diet, exercise, and weight loss. If those don't work, oftentimes we know the geriatric patient is limited on their mobility, and if that's the type of non-pharmacological interventions that are necessary, it may not necessarily work on their own. So pharmacological interventions are necessary. These include things like diuretics, vasodilators, antihypertensive agents, and inotropic agents as well. Assess the patient's compliance with their medications. Again, are they taking them as they need to? Are they taking them appropriately? Dysrhythmias. We know that the number one leading cause to dysrhythmias is going to be a myocardial infarction or an MI. These are going to lead to decrease in blood flow to the heart and or electrolyte imbalances. Treatments considerations are really going to depend on the type of arrhythmia, Most dysrhythmias may be the only indication of a myocardial infarction, so we want to try to recognize that if we see a patient who's suffering from a dysrhythmia, that in the back of our mind, the likelihood of them having an MI, or at least the thought of that, needs to be prevalent. We also want to make sure that we recognize that is this a new onset of AFib? It can happen for whatever reason. Is your heartbeat regular or irregular? Those are going to be things that we're going to want to pay close attention to. Aortic dissection or aneurysms. This again happens with atherosclerosis, with hypertension. We get the hardening of those artery walls, making it more difficult for them to expand. We have Marfan syndrome and blunt chest trauma are probably the most common causes you would see. And we're typically dealing with the distal portion of the aorta. That actually is where these aneurysms will occur, just before it bifurcates off to split into the pelvis and go onto your right and left leg. That's most commonly where you'll see this. So a triple aortic aneurysm in the abdomen is common. Signs and symptoms that you may see: tearing chest pain that radiates through the back. This is going to be describing as a lightning-like pain. This is most associated with a thoracic separation. Worse initially, but feels better as it travels down the aorta, right? So we see that tearing, but it gets better as it goes. Well, why? Because we know those vessels are going to grow in size. The tearing abdominal pain or unexpected lower back pain is normally associated with the AAA. We also are going to watch for things like decreased pulses, cold extremities, and know that if a rupture of that vessel, of that aorta, were to occur, cardiac arrest is going to ensue, and the heart is going to respond in a pulseless electrical activity rather than an onset of a lethal arrhythmia normally. And this is most likely going to be fatal. Management, we want to give lots of fluid to these patients, continuous fluid administration. We want to try some drug therapy to lower the arterial pressure and diminish the velocity of left ventricular contraction. Those include things like vasodilators or negative inotropes. And then rapid transport, right? Our primary goal is just to get them stable. We just want to stabilize them and get them to the hospital so that they can undergo surgery. Hypertension we've talked about as well quite a while ago, but hypertension is defined as anything greater than 140/90 millimeters of mercury. Some of the big things that we think about when we deal with hypertension is increased with atherosclerosis, right? Are these hardening of the walls of the arteries, or buildup of, atherosclerosis, the hardening of those arteries. Typically is a primary component associated with obesity and diabetes. Non-specific complaints include things like headaches, ringing in the ears, bleeding of the nose, that's epistaxis, slow tremors, nausea, and vomiting. All those can be also regular signs of aging, so we have to kind of take that into effect as well. Treatment typically depends on the severity and then what type of underlying illnesses do they have, what type of comorbidities or existing diseases do they have. A lot of times for hypertension, you're going to see primary medications administered, right? These centrally acting agents of beta blockers, diuretics, or digitalis or digoxin. Digitalis is an older medication, but if it's working, you'll find that patients are going to remain on it. We also know that central acting agents are more likely to produce negative side effects, right? Because it's distributed through the entire body, it's going to lead to more global problems rather than a specific solution. A syncope is results when blood flow to the brain is temporarily interrupted or decreased. And this can happen for any number of reasons to any number of patients, regardless of age. But we know that the geriatric patient is more prone to these. Things like a vasodepressor syncope, where they're taking a vasopressor medication and it ends up making it worse for them. Maybe they vasovagal out or have orthostatic syncope. They stand up too quickly and they lose their balance. That's an example, or pass out. That's an example of an orthostatic syncope. Vasovagal, they're constipated because the medications are on. They're trying to bear down and they vasovagal themselves out. Maybe it's a cardiac arrhythmia or a seizure or even some type of stroke or transient ischemic attack. Other neurological disorders we talk about include things like CVAs, seizures, dizziness or vertigo, Parkinson's disease, and then the debilitating cognitive diseases such as delirium, dementia, and Alzheimer's. With strokes, they usually fall into one or two categories, either ischemic or hemorrhagic, and either can happen to our patient who is geriatric. We know that falls are oftentimes associated with an increased likelihood of hemorrhagic bleeding into the brain, and so we want to try to assess if there's been any type of fall. We're going to present with altered mental status, coma, paralysis, slurred speech, changes in mood, or even seizure-like activity. These treatments are primarily focusing around the severity of your patient. They include things like your Glasgow Coma scale, making sure that you determine if they're having an effective score. Remember, typically 8 or more is good. Less than 8 requires advanced procedures or advanced care. We want to consider rapid transport, especially if we're assuming the patient's having a stroke. Fibrinolytics can be administered within 3 hours if it's an ischemic stroke. We know that the majority of those strokes are ischemic. And then other things that we would consider, for example, checking a blood glucose to rule out that there's any issues with that, assessing for a fever, doing a Cincinnati or pre-hospital, Los Angeles pre-hospital stroke screen. Those all become very important. And then following our FAST mnemonic from the American Heart Association. So for facial droop, arm drift, speech problems, and then immediately recognizing the time and then getting them to the appropriate transport facility. Seizures, oftentimes seizures are mistaken in the elderly for CVAs. Seizures can occur for any reason, especially if there's been damage from a previous stroke. Most common causes for seizure are idiopathic, and so it's hard for us to determine what the reason is. But do they have a history? Has there been any recent change in medication or environment? Anything that would be an acute change can lead to a seizure-like activity. Recognizing the seizure is important and transporting quickly as possible, especially if you're believing that it is a stroke-related or CVA-related seizure. Dizziness and vertigo, everybody can have these, but we also know that because of the underlying deterioration of the structures of the ear and the shrinking of those structures, we know that these folks are going to oftentimes be more prone to balance impairments and dizziness, right? So it can be an indication that someone has suffered from a syncope or maybe a near or pre-syncope. Maybe they just have some lightheadedness or they actually have true vertigo. It's very hard for us to determine what the true cause of this is, but we want to be able to recognize the symptoms. Those symptoms are often going to be accompanied by sweating, paleness, nausea, and vomiting, which would typically raise or at least heighten your index of suspicion for a more acute problem. It is virtually impossible for us to distinguish what type of problem they have: dizziness, syncope, pre-syncope, vertigo in the pre-hospital setting. We just can't determine those things, but we can treat them appropriately and make the patient comfortable. Considering antiemetics is a primary thing, we consider making it darker for our patients, making it more comfortable. Now, when it comes to delirium or dementia, Alzheimer's disease, these are all a chronic global cognitive impairment disease. These are often progressive and irreversible, and out of those, Alzheimer's is probably the most commonly recognized disease. Delirium, by definition, is a global mentation impairment of sudden onset and self-limiting duration. So they've got a global problem with their ability to function and to understand input that's coming in, but it has a self-limited duration, so it's not going to last for forever. But it's a rapid, sudden onset. Would be an example of delirium. Most of the time, these will have reversible or treatable causes: intracranial bleeds, tumor growth, infections, or maybe medication toxicities. Those would all be something that we would recognize. But again, delirium is that initiation of global impairment with a rapid, sudden onset and self-limited duration. If we're trying to compare dementia to delirium, dementia is slow, delirium is rapid. Dementia is irreversible, and delirium may be treatable depending on what it is and if it's treated early. We know that dementia impairs memory, and delirium more so impairs attention or attention span. Dementia is going to deal with global cognitive deficits, and you're going to be seeing with delirium more focal cognitive deficits. Most commonly, we think of dementia as caused by Alzheimer's disease, and where delirium is most commonly caused by some other systematic disease: drug toxicity, metabolic changes, stroke, things of that nature. Dementia does not require any immediate treatment. It just requires primarily supportive care. Delirium requires immediate treatment, and so we want to make sure that we recognize the characteristics of each of these, dementia and delirium, and then be able to compare and contrast them to recognize when and where we should be rapidly and treating our patients, effectively treating our patients, and when a more slow, soft, skilled care approach is needed for our dementia patients. We talked about the delirium already quite a bit. We've talked about the signs and symptoms. Again, disordered thinking, psychosis, irritability, forgetfulness, excessive energy, paranoia. Any of these can be wrapped around into delirium. The key here is it's a rapid onset with an acute change. We want to try to be able to distinguish between delirium and dementia. Err on the side of caution with delirium, because we know at least then we can search and treat reversible causes. With dementia, dementia is a more more prevalent in the elderly than delirium. Organic brain syndrome or senile dementia is common, but we are oftentimes going to find that this is a progressive disease with shortened attention spans, aphasia, nonsense talking, or hallucinations. We also know that often this is going to often hamper treatment through the patient's inability to communicate, and can really play a toll on caregivers, especially for those that are at home with them. That's why we need to make sure that we're alert to anyone who suffers from dementia that there's a possibility that they could have a form of elder abuse. And so with dementia being so progressive and being so debilitating over time, we want to recognize that. Alzheimer's disease is the most common form of dementia that we think of. It's a chronic degenerative disorder that attacks the brain and results in impaired memory, thinking, and behavior. We also know that Alzheimer's leads to atrophy of the brain, or shrinking of the brain tissue. This happens normally in adults as they age, or geriatric patients I should say, but it's definitely more prevalent, and it's diagnostic when we use some type of CT scan to see the type of atrophy and physical changes of the brain. It occurs in stages, so we know that those stages include early stage, the intermediate stage, and the terminal stage. The early stage is where we're dealing with primarily disruptive components, but not beyond short-term memory problems, maybe some paranoia, even being just forgetful. The disease can progress rather quickly. The intermediate stage is now they have a difficulty or inability to learn new things. They wander more, they fall more, they begin to get lost, and then they have problems maintaining self-care, things like bathing or using the toilet appropriately. And our final stage is terminal. This is where the individual loses the ability to walk. They truly regress into more of an infant-like behavior, and they lose control of their GI abilities. The biggest thing you have to recognize is there's not much that we're going to do to treat Alzheimer's in the field. There's nothing that we're going to do to treat Alzheimer's in the field other than be supportive. We have to remember who is our patient and how many patients do we have. We want to make sure we recognize this is a very difficult process for families to go through, and so we want to try to have compassion for the family, make the patient as comfortable as we can as we move forward in our care. Parkinson's disease is another degenerative disorder. It's characterized by changes in muscle response, including tremors, loss of facial expressions, and gait disturbances. It affects basal ganglia in the brain and leads to a number of different degenerative progressions of symptoms as time goes on. Parkinson's, again, the initial sign is a resting tumor combined with a pill rolling motion. Where you're going to find that in their hands are, because you're going to like roll a pill. It's almost just like a natural habit that they have. Muscles are progressively going to become more rigid, and movements become slower, and they become more erratic, more jerking-like motions. Commonly, these develop mask-like faces, devoid of all facial expressions. They just lose the ability to have facial expressions because they're losing control of their muscles. We want to try to manage treatable conditions and transport as needed, but for most of this, you may really be relying on the family to help you identify the proper care, at least for supportive measures that the patient will need. We think of a number of patients who have had Parkinson's disease. Metabolic and endocrine disorders. Diabetes mellitus, type 2 diabetes is more prevalent in the elderly, basically because of lifestyle choices. We know that conditions may present in early stages with symptoms such as just fatigue or weakness with diabetes. And then the management of these diabetic and hypoglycemic emergencies for the elderly are generally the same as for any other patient. They may take a little bit more time in popping back, especially with hypoglycemia, but really, again, it's going to be the same care we would provide. Thyroid disorders. The thyroid is, in essence, it's just it affects your entire body, right? It affects most of the physiological processes within the body, and we've talked about these adrenal these hypothyroidism issues. They include things like hypothyroidism, non-specific complaints from your patient. You're going to see mental confusion, anorexia, falls, incontinence, and decreased mobility. You may also find that it's very cold in there because they generally just can't have good temperature regulation. Hyperthyroidism, typical symptoms of heat intolerance is often prevalent. And then non-specific features as well, such as AFib, failure to thrive, abdominal distress, diarrhea, exhaustion, and then depression. GI issues, we can have upper and lower GI bleeds, bowel obstructions, and mesenteric infections or infarctions, twisting of the bowel. Upper GI bleeds, these are going to be mostly caused by ulcers or gastritis. It could be from esophageal varices or a mallory Weiss tear, as we talked about before. Lower GI issues or bleeds can be caused by diverticulitis, tumors, ischemic cholecystitis, or arteriovenous malformations. Other things that you're going to see is going to be the presence of coffee ground emesis. You can see in the image below. Tar-like stools. Melena is what we're going to be dealing with there. That's, again, digested blood. Obvious blood in the emesis or stool. Orthostatic hypotension. Or a pulse rate greater than 100. Now, unless they're on some type of beta blocker, because that's going to blunt that natural response of the heart. And then we deal with confusion. Bowel obstructions typically are going to be involving the small bowel obstructions. And can you guess what those causes are? That's it. You said so. Decreased GI fluids, saliva, acids, and bile. We also notice that we're going to have a slowing of digestion, a decrease in peristalsis. Patients will typically complain of diffuse abdominal pain. They're bloated, they're nauseated, they're maybe having some vomiting. All these are very common. You may also notice that they have a fever, weakness, even signs of shock, and then various types of electrolyte disturbances as this progresses. Now, a mesenteric infarct is something that is difficult for us to assess in the field, but it is definitely something that can cause some problems to our patient. There are certain age-related changes that make the elderly more vulnerable, things like AFib or swelling of the bowel. And these primary symptoms of a bowel infarct is where pain is out of proportion to the physical exam. Oftentimes the patient is at a great risk for shock for this, and they're going to clearly denote it. There's a blockage in the blood vessels that feed the bowel, and because of that, the tissue is actually going to die. Skin disorders, there's a number of skin disorders. Herpes zoster, pressure ulcers are probably some of the more common ones that we would see. Pertussis, or also known as whooping cough, can cause dermatitis or eczema based on environmental conditions. And then oftentimes we know that it can be susceptible to bacterial or infectious wounds because of the openings in the skin. Herpes zoster or shingle virus, this is extremely painful. It's a nerve infection and it's secondary to chickenpox. Just because you had the chickenpox or the varicella vaccine does not mean you're not going to get shingles. Treatment is mostly going to be palliative care, but we definitely have to make sure that we're trying to make them as comfortable as we can, recognizing that this is a very significant amount of pain that can happen with both of these illnesses. Pressure ulcers or D-cube ulcers, these have a very high occurrence in nursing homes, or even homes for that matter where the patient is bedridden, anywhere that someone is bedridden. Typically, they're going to be from the waist down over any type of bony prominence in these bedridden patients. And what happens here is the tissue is compressed, there's not adequate blood flow, and eventually the tissue begins to go through a process of necrosis and rot. These can often be very deep and can require a significant amount of ongoing home care, including things like hyperbaric wound care treatment. Prevention is to roll them as much as we can hourly. Osteoarthritis for musculoskeletal disorders. Osteoarthritis is caused by obesity, primarily disorders of the joints such as inflammation or arthritis. It can be by trauma or congenital abnormalities such as things like hips dysplasia. What ends up happening here compared to a normal joint is with rheumatoid arthritis, we're going to see bone loss that's going to occur, a thickening of the synovial membrane itself, and then eroded cartilage. We're often going to find there's going to be a lot of swelling and edema in the joint capsule as well. In osteoarthritis, now we're talking about things like bone spurs, the synovial changes, or any type of degeneration in the cartilage or the padding will happen as well too. So we are going to see a number of different changes, but the primary between rheumatoid and osteoarthritis is going to be that rheumatoid is going to lead to inflammation, and osteoarthritis is just leading to more of a wearing away of those protective structures and adding bone spurs. Osteoarthritis presents initially as joint pain worsened by exercise and improved by rest. Affects mobility, joint deformities, and crepitus or grating sensations. The biggest thing for this is to recognize it and to treat it early on. You may find that osteoarthritis that they're going to be on some type of calcium supplement to help support their bones. Osteoporosis. Now we're talking about risk factors here. Again, dealing with the loss of calcium. Persons with osteoporosis are usually asymptomatic until they actually have a fracture in the spine that occurs. There's not much that we're going to do for this in the field besides make them comfortable, but recognize that the history of chronic back pain or chronic problems with lacking calcium can lead to more concerning problems. Spondylitis, this is normally a form of inflammation of arthritis, but it affects the spine. And in essence, because if it consists, new bone is going to be formed, and that gives us a very stiff, inflexible spine. And so one of those things that will happen is we have a normal S curve to our spine, we lose that, and we get more of a straightening of the spine because of the spondylitis. Now, the fused spine can be extremely fragile and subject to fracture. So there are some considerations that we have to recognize here. First is airway management techniques. We've talked about making sure that we can actually align our patient appropriately to manage their nasopharyngeal, their oropharyngeal, their laryngeal axes, so we can see and manage and place an advanced airway. Those techniques are going to need to be altered because we're not going to be able to put our patient into a sniffing position. Same thing goes for fractures. Splinting techniques are going to have to be very different depending on the component of the spondylitis. And then even transporting. How are we going to be able to transport these patients safely and comfortably? With renal disorders, we know with the renal disorders, we're dealing with a ton of different issues. Glomerular nephritis, I can never say that, and renal blood clots. So inflammation and then blood clots is the big two that we're looking for. Two big age factors we deal with is we lose our kidney size and we lose our kidney function because of the changes of the walls in the renal arteries. This leads to inability for the body to filter its blood, and so we see toxicities begin to accumulate along with medications in the bloodstream. Most of your urinary disorders are caused by bacteria and lead to urosepsis. We can have a lot of contributing factors to this in regards to hygiene or medical conditions, things like diabetes. But we're typically going to be able to identify a UTI in regards to a foul-smelling urine and urinary complaints. Urosepsis is a little bit different. This is now we're thinking about more along the lines of septic. Our patient will be septic or have septic shock, fever, chills, abnormal discomfort, and other signs of septic shock, including things like elevated heart rate, hypotension. Environmental emergencies are another factor we have to consider. These include things like hypothermia. Predisposing factors are always critical. So what medications are they on? What other type of underlying medical conditions do they have that could affect their ability to determine proper temperature sense? Maybe they would have diabetes or some type of neurological problem. These are non-specific complaints we're typically going to see. Slow speech, confusion, they're very sleepy. They may have hypertension and tachycardia initially, but as the hypothermia continues, that will begin to dissipate, and we'll see bradycardia more of as a late sign. And even in the elderly patient with hypothermia, it often does not shiver, similar to that of an infant. Prevention is the preferred treatment, right? So we want to make sure that we're able to recognize if there's an issue with finances or sensory issues early on. Hyperthermia, again, they're not going to be able to sweat. They become heat. They prefer the heat. And so because of that, we know that the heart disease place elderly at a higher risk. And other risk factors exist as well. And so many of these are non-specific for signs and symptoms. Temperature is probably your best indicator. And then again, the same type of prevention strategies we looked at with hypothermia. With hyper and hypothermia, here's the key. Make sure we're recognizing it, recognizing your scene, and then treating them appropriately as we would almost any other patient. Tox emergencies. One of the big things with tox emergencies is that we oftentimes will deal with accidental overdoses that occur more frequently. Half of all drug-related deaths occur in new patients over the age of 60. That's because of new medications. So assessing the patient history well is important, right? Any chance that medications are building up in their system, we want to know. Is it getting away from their system? Maybe they've missed doses. It's important for us to assess that polypharmacy. Most of the medications that you're going to see that they're going to be on, there is a ton of them. They exist in everything from components of like lidocaine, beta blockers, antihypertensives, diuretics, ACE inhibitors, digitalis, antipsychotics, Parkinson's medications, analgesics, corticosteroids, you name it. The list goes on and on and on. We do know that substance abuse is prevalent as well in the elderly. Age-related changes, employment changes, loss of a spouse, maybe they're on multiple medications, so on the average, remember, they're taking 13 medications sometimes, as much as plus over-the-counter medications. Maybe they're dealing with malnutrition, loneliness, or maybe they've lost their home. Maybe they're moving to an apartment or some type of assisted care center. Those can lead to issues with substance and drug abuse. Now, drug abuse can actually lead to a lot of signs that would point you into another direction of another medical condition. These include things like memory changes, drowsiness, decreased vision or hearing, orthostatic hypertension, poor dexterity, mood changes, falling, restlessness, and weight loss. Now, here's the key behind this, guys. If it's substance or drug abuse, regardless, we oftentimes don't think of the elderly as someone that has those types of problems, but recognize that they still can, and that needs to be part of our assessment considerations. Alcohol abuse is another example of this, right? Alcohol places the elderly at a very high risk of toxicity. We know that their liver function's not where it is, or where it once was, and can lead to a buildup of those toxins in the system. Persistent findings you will see will be mood swings, denial or hostility when questioned about alcohol abuse, maybe some confusion, they've had some falls, anorexia, insomnia, visibly anxious, and then nausea. Those would all be common problems associated with alcohol abuse. Now, we also have behavioral and psychological disorders. We oftentimes think those go hand in hand with some of those substance abuse problems, but not necessarily at all. Common classifications of psychological disorders related to age include things like organic brain syndrome, depression, dependent personalities, and paranoid disorders. Most of these emotional disturbances really affects the well-being of the elderly patient or their overall physical health as part of that. Oftentimes, the behavioral or psychological disorders may accompany some type of alcohol or substance abuse. Symptoms of depression is the same that we would see for anyone, but we have to recognize that the geriatric population is not immune to this. They may feel sad or have be in just a sense of despair. They may have had some type of past psychological treatments and even some type of current stressful event that could have led to this. And then the depressed patient should receive supportive care. There are some things that we still need to do. There are some key things that we need to know here when it comes to depression. So we surveyed 100 people in this studio audience, and here's what we found out. Depression is the leading cause of this among the elderly, which is suicide. We also see risk factors where suicidal behavior is related to stress. We see that there's a higher incidence of suicide among the terminally ill, and depression is the leading cause of this in the elderly. So we want to make sure that we're being attentive to the personnel and to the crew safety, because if they're interested in killing themselves, they may be interested in harming you. Trauma in the patient. Trauma is the leading cause of death in the elderly. There's a lot of contributing factors. We talked about those as we went through, but we need to make sure that with trauma that we approach our geriatric patient in a little bit different fashion than we would a standard healthy adult. Our general assessment focuses primarily on the geriatric's underlying conditions. We know that blood pressure and pulse readings can be deceptive indicators of hypoperfusion, right? The perception of pain is also diminished. So things like blood pressure or tachycardia aren't always going to be great signs for us to utilize anymore. If anything, they may be a late sign. One of the best indicators of shock in the elderly is an altered mental status, recognizing that the inadequate blood flow to the brain is going to be causing that initial problem that we see, that we may be able to dive backwards into and determine that it is some other underlying problem of shock. We know that abuse and neglect is a very common form of traumatic injury, a syndrome in which an elderly person has received serious or physical or psychological injury from a family member or other caregivers is defined as abuse or neglect. Most of the time with these abuse and neglect cases, the injuries are unexplained, and that's how these cases will present. Someone's been hurt, there's been an ambulance has been called, and the story does not necessarily match the symptoms. Pay very close attention to particular inconsistencies, but don't confront the family. Transport the patient, be supportive of the situation at hand, and then document and report those findings to the appropriate authorities. We don't want to make the problem worse. Most of the general management when we're caring for elderly patients, we want to consider the various changes and underlying conditions which may affect your care, such as cardiovascular considerations, respiratory, and renal considerations. Cardiovascular considerations of recent myocardial infarctions or a decreased response of the heart and adjusting heart rate and stroke volume. We have to make sure that we recognize that those are considerations that can really affect our patient. Care must be taken in intravenous fluid administration because of decreased myocardial reserves. We can't put them into a fluid overload. And we also have to remember that certain medications can make it harder for the heart to be able to function. Respiratory consideration, age-related changes can decrease chest wall movement and vital capacity. Age also reduces the tolerance of all organs for anoxia. Positive pressure ventilation should be used cautiously. Why? We know that the geriatric patient has a very weak and fragile lungs, and if overventilation happens, we oftentimes can lead to gastric distension and or a spontaneous pneumothorax. Renal considerations, a decreased ability of the kidneys to maintain normal acid-base balance and trying to compensate for fluid changes is a very difficult thing for the geriatric patient to do. This, on top of pre-existing renal disease and toxins and medications that may accumulate readily, all lead to a big problem for the patient and their renal system. We know that if we're going to have to transport, we're going to need to do some additional considerations. These considerations include modifying the positioning and immobilization and packaging. You may often ask yourself, how am I going to be on this, right? How am I going to make sure that I can do this? How am I going to make them as comfortable as I can? Oftentimes remember that your backboard now is used as a transport device and that they should be removed from that device as necessary. We also know that trauma places a patient, a geriatric patient, at a very high risk for hypothermia. And so we need to make sure we maintain that warmth and covering our patients up with appropriate blankets. Specific injuries that we'll go into, we're going to talk about orthopedic injuries, burns, and then head and spine injuries. With orthopedic injuries, hip and pelvis fractures are probably the most common that we would see. Most fractures you will see are going to happen in the proximal humerus, hip, pelvis, distal radius, proximal tibia, and thoracic and lumbar bodies. Now, burn-wise, there are risk factors. We know that the patient's already going to have a weakened skin, thinner skin, less body fat tissue to help maintain warmth, inability for fluid administration to be very effective because of the renal issues. All of those become a major concern. So when a patient who is elderly suffers from burns, they're at a much higher increase for shock. Complications from burn may manifest themselves in days and weeks following the incident, depending on the fluid shift and the underlying condition, comorbidities of that patient. With head and spinal injuries, a major factor in head injuries is the difference in proportion between the brain and the skull. Remember, in the geriatric patient, their brain will atrophy, it will shrink, meaning there'll be more room for that brain to move around. We also know that the cervical spine is also more susceptible to injury due to osteoporosis and spondylitis. Arthritic changes can gradually compress the nerve rootlets or spinal cord, and trauma obviously is going to put more of a risk of the spinal cord. And so when we think about our geriatric patients, we have to summarize a couple key factors. First, epidemiology and demographics, that this is a special population, and that we know that there's a very large population of geriatrics that we'll be serving for many years, and that we need to have the proper system capabilities to do that. We know that our general pathophysiology assessment and management is critical to handle these certain circumstances. We have to recognize that the geriatric is unlike any other patient. They are going to have more of a unique feature because of their aging and underlying conditions. Most of the time when we think about system pathophysiology in elderly, we're really dealing with that one system affects another. And as each system has an underlying disease process, it begins to sway the normal functions of the body out of homeostasis because of that, and can have a systematic effect or system-wide problem for our patient. We've talked a lot about the common medical and trauma problems in the elderly, recognizing the way that most care is provided is going to be based off of good communication, recognizing and looking for clues that may be outside the normal for a regular, healthy, young adult or adult. And so with that, I'd like to conclude our lesson on the geriatric patient. I know it's been very interesting for you. And I think if I had to sum up this entire lesson, it just really goes to show you how crappy it is to get old. But it is part of life and something that we need to deal with. So thank you guys, and we'll get started on our next video lecture shortly.